can do is overreact. You can say, you could, for example, look at this graph right here and say, well, the 3 things we had, the greens, those were really good, and now we have the red, something bad's really going on. I don't actually know if this gives me a light. Doesn't look like it. So right, you could look at the green followed immediately by a red, and if you just look at those 2 data points, you're like, we were doing really good, now we're doing something really bad, and you could go chase down whoever is in that unit for those red dots and start being upset and getting mad at people. But ultimately speaking, if you look at the whole thing, that's a mistake because that's a stable system. There isn't one unique thing going on that's driving that red dot. That red dot is expected. It's part of the system. It's common cause. Therefore, that would be an overreaction. It's important to document as we're making changes so that we can always go back and say, well, we made this change and it had this. So it's important to document as we're looking at measures so we have that kind of historical context, but also as we're making changes. And then the importance of feedback loops. So when we learn something, we want to make sure that we're feeding it back into the system, changing the way we're collecting our data, right? You might go back to your data source and get a new data source. You might go back to your data management and change your validation. And then this is my last slide, but the role of just cultures and measures. So measures will generally reflect aspects of a system, like structure and process, and multiple individuals working together. So we want to avoid the barriers to just culture where we're going to blame or kind of have an outcome bias where something bad's happened and then we're working backwards to say who is responsible for this. And then lack of transparency, inconsistent assessment. So as we're using these measures, we want to make sure that our stakeholders are involved and kind of know what those measures and how those measures came to be. And at the end of the day, for everybody here as a leader, we want to use these measures, ultimately speaking, to interrogate the system. How's our system doing? We want to learn from those special causes, right? The person who comes in for a special shift and created an odd dot or duck, and you want to kind of look and learn from those. You want to encourage and trend improvement, and then you want to celebrate improvement and maintain those gains using those measures. And I think that was it for me. Thank you, guys.
Thank you, Dr. Champagne. I'm going to see if I can actually get my slides on the screen here. All right, can everybody see that okay? All right. So I'm Dr. John Kruger. I'm the Chief Medical Officer and Chief Quality Officer for the Chickasaw Nation. We're a tribal nation located in Oklahoma. We cover a 13-county area of Oklahoma. It's really my privilege to be here with you today. And really want to thank Dr. Champagne for his introduction there. That's a really good overview of how quality works. What I'm going to try to take you through today is basically how we're using quality as a way of running a health system within the Chickasaw Nation. So that's what my talk will be about today. So this is our beautiful campus. We have a wonderful 75-bed hospital and 4 outlying facilities across our 13-county area. We are working on another facility that it's a little premature to release right now, but we're really excited about that. We take care of roughly between 90 to 100,000 patients. And when I talk to you about quality today, I'm going to predominantly be talking about healthcare quality. That's not the only type of quality you can measure, and it's certainly not the only thing to be concerned about within a tribal government. But from my perspective as a Chief Medical Officer, Chief Quality Officer, I'm predominantly going to be talking about health. Before I get started on our mission and vision, because I think this is really key to why we've been successful. But quality, there was a gentleman by the name of Vedas Donabadian, and he used to have a quote, and you'll see it if you Google out there, Google him, that he says quality is about love. And really that's what it is about. Health quality is really about love for a population, and it's different than loving just a person. It really means to take the health of that group of people very seriously and at a very deep level, and think about that in depth about how you would take care of a group of people and show them that kind of attention that they deserve. So within the Chickasaw Nation, we are a very mission-focused organization. Our overall mission is to enhance the overall quality of life of the Chickasaw people. And our vision is to be a nation of successful and united people with a strong cultural identity. We live off of 10 core values, and I won't go into all of them here today, but these core values are very important to us in our day-to-day work. Why do I talk about mission, vision, and core values? Without great leadership, without leadership that is focused on the love of their population and their people, it is very hard to achieve quality within an organization. So you have to start from that perspective, I think. And that's certainly what we've had within the Chickasaw Nation. So in April of 2018, our Governor Anatubby, set a vision for We Are Quality. You will see that on every part of everything that we brand. We put We Are Quality on. That is how we run our system. That is our day-to-day plan. I'm here as part of that vision. In 2019, they were kind enough to create a job for me as Chief Quality Officer. So I got to come back to Oklahoma and work for the Chickasaw Nation. It's been fantastic. We are also working with a group called the Oklahoma Quality Foundation. And Oklahoma Quality Foundation is basically, if you have this in your state, most states will have this, folks that are interested in working on baldridge, on a baldridge enterprise, which we are. We have adopted a baldridge methodology for our quality strategy. And Oklahoma Quality Foundation is who we partnered with at our state level. And I'll talk a little bit more about that later. We have a multidisciplinary group that was started in 2018, and they created a strategic plan, which you'll see below. Those small, if you look right over here, sorry, I don't know if this works. Nope, it doesn't. But if you look at these, each one of these characters we created, and it specifically attaches to a goal. So across our organization, you can just look at one of those avatars basically and determine which goal we're talking about. So we have basically 5 goals I'll go into in a minute. In 2020, we utilized the Baldrige framework and the quality improvement methods to successfully navigate the COVID pandemic. I'll show a little bit about the data and the quality that we applied to COVID and being successful there. Just in short, we use lean and Toyota production system methodology because we felt that if you were coming for a test or a vaccine, you need to have a good customer service experience. And what patients valued, it turned out, was access and efficiency. So, and now we've just rolled out our strategic plan to our Chickasaw Nation Department of Health employees in 2020. We're continuing to update that strategic plan. So goal 1 that we had as a strategy was to improve our customer experience, and we have a lot of metrics that drive toward that goal. Secondly is to strengthen the employee experience. You heard about just culture. That's one of the things that we believe in very much. Even though we measure a lot of things, quality is not a club that we use to beat people up with. Quality isn't to embarrass people or to shame others. You won't get very far. We need those folks to help us love our population, so to speak. So the way that you help your employees is by actually honoring and loving your employees and making them buy into that quality experience. Optimizing performance through organizational alignment, making sure that we're all focused on the same thing as one Chickasaw Nation. Improving technology systems, analytics, and reporting. Yes, we are getting a new EMR in time. We are still on RPMS, but that was a big thing that our clinicians wanted and a lot of our staff wanted. And then expansion of services. We continue to expand services across our organization. So when I talk about quality, what are we talking about? I mean, what does that mean to folks when we say high quality? I think if we all ask ourselves, we all have different measures of what quality means to us personally. These are just some standard definitions that you'll see out there. The standard of something is measured against other things of a similar kind. The degree of excellence of something, an improvement in product quality, the hospital ranks in some level. And you see within quality descriptions a lot of times what Philippe was talking about, and that is things that we use quality a lot of times, and sometimes we're using it for judgment, sometimes we're using it for research, sometimes we're using it for improvement. A distinctive attribute or characteristic possessed by someone or something. He or she shows leadership qualities. From our standpoint in the Chickasaw Nation and within the Department of Health, we're really running a quality performance program. And that's really, quality is our business strategy. That's how we're going about what we're doing on an everyday basis. So our quality metrics are how we basically see how we're doing. It's our feedback loop to ourselves. Are we making progress in the things that matter to our population who we really want to be of help to? You heard about structure and process, and I think I forgot to include that slide here, but you really heard about it. But there is an old adage out there that structure plus process equal outcome. So there's another adage about performance. And that performance is really about behavior plus results. You have to show results at some point. Results come and go, behaviors don't. That's why that core values, that's why that mission focus, that's why it's so important, because that guides our behaviors and that allows us to be successful. Just like Dr. Champagne was talking about, our methodology that we're using is the model for improvement. This was devised by the Institute for Healthcare Improvement. I found the IHS is using much of the same methodology as the model for improvement. I confess I am an IHI I'm a person that is steeped in IHI dogma, I guess, if you will. I was a 2010-11 George W. Merck IHI fellow, and so this is what we use. But there's plenty of other models that you can use for quality improvement. If you're interested in that, Lean's one. We use some Lean. Toyota Production System is another type of methodology. Baldrige is a methodology, but for quality improvement, this is the model that we use. Within this model, we have something called a Plan, Do, Study, Act. You'll also see this referred to as a Plan, Do, Change Act. Dr. Edwards Deming, who came up with the PDCA cycle that was later converted to the PDSA cycle, basically these are small iterative tests of change. If I had to give you a great example of small iterative tests of change, how many people flew here with a mom who had a child on an airplane? Okay. How many times did that mom try to do something with that child to make that child be quiet or be happy and stop crying? That's a small test of change, right? You don't know if that's going to work, but you're going to bounce them on your knee, do the video, do the food plus video, bounce on the knee a little more. I mean, you try as much thing as you can, because if you've ever traveled with a small child. So PDSA cycles in real time, just look for moms on airplanes. You'll find plenty of examples of that. The idea is you build belief about something works, right? This is how we all do things in life. We have to believe. Some of us have to go and put our hand on the hot stove, and then we maybe go back 2 or 3 times. But usually we figure out that, hey, that stove's hot, learn my lesson, I'm not going to keep touching the stove. After you've built belief that something works, then you try it on a little bit larger scale. If that works, you try it a little bit larger scale. Unlike research where we hypothesis test and we're very rigorous about this, these things can be sampled in day-to-day data. It's not scientifically valid, if you will, but we're building belief over time. Later on, once you get enough data and you put it in a cycle over time, such as what Dr. Champagne was talking about, you start to come up with what are called run charts and control charts. And by the pattern of data over time, essentially what you're seeing here, I took out the slide that I have, but if you go to this right here, this is a bell curve, okay? It's a distribution of a lot of different data points. What we are essentially measuring on this center line, which will be either what's called a median or a mean, depending on which kind of chart you're using. What we're measuring is the very middle point there on its side. So we've taken a distribution of data, we've come up with a median or mean, rotated that on its side, and now we're going to look at it over time. So if I ask you, if you roll the dice one time, what's your chance you're going to land on heads? If you flip a coin rather, what's the chance you're going to land on heads? 50%. What about twice in a row? What's the odds there? 3 times in a row. 4. 5. So what I'm trying to show you here is that you're really good, by the way. You win. That's awesome. What I'm trying to show you here is that the chance that you're going to have that pattern, that's the difference between special and common cause. Common cause patterns tend to rotate up and down, right? I mean, the chance you're going to get 5 heads in a row, the odds aren't really great. They're not in your favor. If you're seeing a change that looks like one of those patterns that Dr. Champagne showed you earlier, you're probably seeing something improve in your system, so to speak, or not improve. It could go the other way, if you will. I will say that there's a couple things too as you go into quality improvement that you have to be aware of within an organization. How many folks here have had a great idea, they've figured out something really important, and they take it back to their organization and they say, oh, I just learned the greatest thing. This is going to change everything as we know it. And you show it to the group, and then what happens? Yeah, that's great. Oh, thanks. Yeah, we hear you. Yeah. The water faucet's still broken in the bathroom. You didn't get that done for me. And by the way, the EMR is still broken. It still stinks. So, yeah, the challenge with this is something that Rogers, so this is Rogers' diffusion of innovation curve. I always put this up here to remind me that within any organization, about 2.5%, and again, these aren't real numbers per se. I think you'll see differences in different organizations. But only about 2.5% of your employees are going to be really interested in making change. Like they've already made the change probably before. By the time you come back from the conference, they already heard you're at the conference, they learned what you knew, and they've already put it into place. That's your innovators. Your early adopters are kind of watching that first group, and they're going, that guy's pretty good, so I think I'm going to do what he did, and they're kind of going the next one. But the group you really want to get to is that early majority. If you can get to the early majority, you're probably going to have success with that. And then later on, the later majority. The laggards, these are the folks, they're from Missouri. They're from the show me state. You don't have to just show them once. You got to show them again and again and again and again. And they have to touch the hot stove about 6 times. So the other thing is, there's lots of ways to do something called change management. This is a great term that you'll hear used out there a lot, and there's 1,001 ways to be involved in change management. Cotter happens to be one of the biggest and most famous names that you'll see out there, and he has 8 succinct steps. I will promise you, never in my life have I ever changed a process where we went from step 1 to 8, all in that nice little circle that Cotter describes. Cotter taught at the school that I went to, and I have not met anybody in that class that it worked the same way for either. But it's a good, it is in general the kinds of steps, and I think it's helpful whenever you're making changes. We did purchase go ahead and partner with an organization by the name of Health Catalyst this last year. One of the challenges we had as an organization was actually, as we started to look at the various sources of data that we had across the Chickasaw Nation, we had data in a lot of little places. So we had 8 or 9 or 10 different applications that had pieces of our data in it, and those applications didn't talk to each other. So we actually built something called an electronic data warehouse. Just like your warehouse, where you store supplies and paper or whatever else it is, we store data here. And what Catalyst has done is they've come in and helped us organize our data into ways that we can find it and pull it out of that warehouse and then put it into visualizations and things like that that we can actually do really cool creative visualizations and other things with and learn from. So Catalyst has its own way of looking at the world, but basically they believe heavily in best practices. We kind of translate best practices as things that we use sometimes, but sometimes we don't know what the best practice is. We're trying to improve something that really there's no real best practice for, so it could just be best idea at the time. We look at analytics. We try to gauge adoption by the methods I showed you earlier, change management, understanding where folks are, going where the energy is, as Maureen Bisignano likes to say, who was a former CEO of IHI, and then going to outcomes improvement. I'd be remiss in not talking about something if I didn't bring this up. You know, in health outcomes, what we're really talking about is morbidity and mortality. We're talking about people getting sick before they should have gotten sick. and people dying before they should have died. The factors that lead to that are myriad, but just keep in mind that 30% of the factors that drive that are what we call health behavior. We can help with that, sometimes in the health system, many times outside of the health system through policy, public health, however that might be. Clinical care, even if we do clinical care really, really well, that's me being a doctor. I am a doctor, even though I do doctoring over a group of people, I guess you could say. But even if we do great medical care, we don't really bend the lever on people's health. So I want folks to be aware that the things that we talk about is social determinants of health, social and economic factors that you see here, things like education, employment, income, family and social impact, and community safety. Those are so important, and they have a much bigger impact many times than all the things we're doing in healthcare. So I'm segmenting a part of the business of healthcare quality today for you, but because I work for a tribal nation that takes all these things into account, we have a lot of levers that many other societies don't out there, many other communities don't, because they're not really focused on some of these things that are driving some of the healthcare that we're trying to treat, and then the physical environment and so on and so forth. Thought I'd show you an example of a scorecard. So one of the things that one of our major projects this year has been to get scorecards, just basically a report card for our clinicians in their hands so that they can see how am I doing? How am I doing as benchmarked? And we use some benchmarking. So we use a little bit of, there's a bit in this slide of quality improvement. There's a bit of data for judgment or accountability, if you will. We also can show the clinician how they rank overall, or we can show our location how it ranks. And then we can show how we're doing according to benchmarks. One other thing I'm a big fan of is we had 33 quality metrics. I don't know who's ever tried to take care of 33 things at one time, but it's impossible because you'll get 4 going up and then you'll get 7 going down. So we use a composite methodology where we use a composite, we actually weight the quality measure and we make it, some quality measures are worth more than others, and we then form a composite score. So this score up here, it wouldn't be valid to any other measurement system you might see out there. You couldn't compare our score to anyone else. And our goal is actually the 90th percentile. So we have set very high percentile goals. We're actually using MIPS, which is actually the merit-based incentive payment system. MIPS came up with really good, it was started by CMS. By the way, if your facility and your physicians don't qualify for MIPS, don't be surprised. It's very unlikely in most tribal health delivery systems that they would qualify for MIPS. But I've worked in the commercial side as well as within tribal, IHS, and government sides. And most government facilities do not qualify for MIPS. There's been some movement to try to true MIPS up with the government sector, but that hasn't happened. But anyways, the point being is that we have 33 different ambulatory quality measures that we're following, and this goes up to composite score. The other part of this is, so this is our scorecard. There's also a dashboard. The dashboard's really a dynamic where you have to log in, look at the dashboard, do things like that. We found that docs don't like to do that. They actually like this to show up in their email box. So this is on paper. Yes, paper. You heard me right. We will also put our data up typically on the wall. So we believe in visualization of data. There's nothing like visualizing data. If it's in the computer, you can't visualize it very well for everybody to see it. But by putting it on the wall, it's something we can look at, and then people start to gravitate to that. This is another really important thing. So on about 7 of our metrics, we're able to use something called number needed to treat. This is a fancy term, but the mathematical term for it is 1 over the absolute reduction in risk. Basically, what we've done is we found out that you have to do X number of something in general to save 1 additional year of life. So our main metric, our main outcome we're going to really be looking at over the next years is how many additional years of life did we save by doing this for a population. Keep in mind, people don't usually come to the doctor for a lot of the things we're measuring. We're measuring colon cancer, cervical cancer screening. We're measuring 7 diabetes measures that are process measures and a few outcome measures for diabetes. We're measuring some metrics around pediatrics. We're measuring metrics around screening for things like tobacco cessation, alcohol, and depression. Things we typically do a lot anyway. So, and it turns out there's about 33 of those. So I'll show you. And then you end up getting these total weighted performance. This isn't from our system because our system is just getting ready to go loaded with this. But you can see in other systems I worked at, sorry, this looks like a Rorschach test. It really isn't, I promise. But this was, these are at a clinical level. We are able to demonstrate data over time. Some of the other things we're working on this year is an access dashboard. And we're trying to understand our access better, in particular around patient cycle times in and out of the clinic. How does a patient move from the front of our clinic to the back of our clinic, get seen, and move back out? If you make that efficient, it can really help out the entire clinic and help the patient experience out. Virtual care, and then general access that we've just started work on. This is a project that is near and dear to my heart. I spent way too much of my career working on opioid safety, and if any of you all have worked in this field, it really is a labor of love. But I am delighted to have a really great dashboard here. We have 5 process measures that we're working on and already did not have a large population of this. The other thing that I'm really proud of is that we've actually created a surgical for our surgeons. How much are they prescribing per each case, by case? So they can look at that. The idea is to get more consistent. There's some pretty good evidence now that patients can go in for an innocent surgery and then become, if they receive a little bit too much of the drug, they can become dependent on it over time. Our COVID response, to date, we've delivered roughly 220,000 COVID-19 tests since the pandemic started, administered roughly 84,000 vaccines. We elected early on, thanks to our leadership, to really provide a broad array of services. And because of that, we had to develop some pretty good tools. We used a company called Qualtrics for that. It's an 8-stage, it does 8 basic things, but these are all app-based, so we have COVID testing, contact tracing, daily screening, employee clearance, random sampling, which was unique to our system. So we actually randomly sample some of our patients within some of our employees within our system so that we can get an idea of how much COVID, asymptomatic COVID is within our organizations, antibody testing, analytics, and we had really robust analytics coming off of this. Just some examples, as you can see, we could see down into the population level and the county level, knowing where we really needed to place resources. So again, we were learning as we went along with COVID and using our data to help us show the way. We used the Lean and Toyota Production System technology. It turned out that what patients valued the most and people valued the most as they came through was a good customer service experience. Even though it was free for the patient and they weren't paying for it, people still were nervous and didn't want to wait in their cars and wanted to have a great customer service experience. So one of the things across Chickasaw Nation is we are, I would say, at least locally and regionally famous for our great customer service. It's something that we really try to give across all of our enterprises. We worked as one Chickasaw Nation, so I had folks that worked as blackjack dealers. Turns out they're very good at doing, turns out they're very good at queuing theory, and they were very helpful in helping us be successful with this. But we were able to get our cycle times down, and that's the total time it took from the time a person drove in to the time they drove out of our facility. We ran a very, very large, one very large drive-through, but we had about 8 to 9 sites at any one time that were going all the time for COVID testing or vaccination. And we were able to keep that cycle time running around somewhere around 18 minutes, and 15 minutes of that was a waiting time. So patients seemed to really enjoy that. The biggest thing for our population, again, this shows an example. This isn't a runner control chart, it's just a time series chart of data over time. But that orange line at the bottom is our employee infection rate. the line at the top is the community infection rate. Now, we're integrated into our communities. We can't get away from our communities. They live with us, we live with them. And so we can't tell our folks what to do when they go home or things like that, but we can control what happens within the workplace to some extent, within reason. And by using, we use this as good feedback for us, along with a lot of other data sources, to really determine what was going on. This has led us to be able to go forward for the future and using a data-driven approach to COVID. We have a 2-indicator system now, which makes, based on the level of COVID in our community, indicates what we're able to do based on your vaccination status for employees. And then for our general community, we can give general guidance to our general community, and that's based on the CDC's current indicator system. Bottom line, for our system as a whole, accountability measures don't always have to be bad, and this is a good one that we're happy to share. Becker's, for the second year in a row, last week came out and announced that our hospital, Chickasaw Nation Medical Center, was a 5-star overall in quality for the second year in a row, so we're very proud of that. And we're 4-star overall in patient experience of care. We will get our 5-star back. For some reason, they took it away, and we got to figure out why. The other thing is, throughout all this, even though the pandemic was going on, we started our Baldrige journey in 2019 and won a Pursuit of Excellence Award. That's basically the award they give you when you show up and agree to participate. But then very quickly in 2021, we were awarded the Leadership and Excellence Award. So we are actually eligible in our first year to go ahead and apply for Baldrige recognition. We're going to go ahead and go through with that. They have suspended Baldrige for this year, but we will, the government has, sorry, not us, but hopefully we'll be able to get it back. It's my pleasure to represent the Chickasaw Nation here today and speak with all of you, so thank you.
Hey, good afternoon, everybody. Got a little bit of time here, so I'm going to be pretty brief and just summarize what we just talked about and give some quick tips, tricks, things that you can do. So James LaForce, I'm Quality Assurance Manager for a small behavioral health clinic in Alaska. We primarily focus on serving the rural communities. So for our communities, our clinic can be the only access to care some of them have without having to fly into a central hub somewhere. And for those of you that aren't familiar with Alaska, that could mean flying a distance as great as from Wisconsin all the way to California to receive some behavioral health care if you actually have to fly into town to get that. And so it's a big struggle out there for delivering easy access care. And so I think for quality assurance, the most important thing for our clinic, we're fairly new. Your foundation of having good software, a good EHR, it was mentioned Catalyst is a great data mining software. Having those software, without it, it makes getting valid data very, very difficult. If your staff have many ways of entering the same data but without a drop-down list so they can free text it into a box, that can throw off your numbers pretty easily, and your quality assurance program is only going to be as good as your data is. So I think that's, if I had a tip for anybody, anywhere doing quality assurance, it would be make sure that your software is on point, or you have the team to grow that out. It'll really be helpful in the long run, getting more accurate results. The other thing that we do is we focus on our clinicians quite a bit. This goes without being covered a lot of the time, and the clinicians are the people that are taking care of our population. And so we do collect a few metrics on our clinicians to make sure that their time is being utilized well and they have plenty of it so that they're not getting stressed out, which then, of course, in behavioral health, that could lead to a stressful, care, basically. So we try to focus on a few other things that are helpful besides the accessibility. Accessibility for us looks like everything from behavioral health is notorious from having long wait lists for individual therapy sessions. So one of the things we do is we monitor our from the time they come in for each different type of referral all the way through actually starting the sessions to see how long each one of those components is taking. We also measure it down to if it's different providers. So we can target training and be meticulous with our data and our quality improvement program. The main thing is with the whole, I don't have much time left here. The main thing is with quality improvement and quality assurance and using these metrics is that they need to be, if you're collecting it, you should be using it. The data, when you bring it in, the most time-consuming part of this whole process is actually going through and validating the data. So again, starting with that good software, that can really ease the staff time for having one of these programs up and running. As we all know, it takes a variety of different people when you're talking about software, your quality assurance, people, then your executive leadership. Everybody should be strategically planning to use this. The other tip I would say is start small with your metrics. If you try to, from the get-go, just try to say, okay, we don't have a program, or our program is, it's kind of unofficial. If you go in and you say, okay, we're going to collect all of these key performance indicators at the same time, it's going to be very difficult to do that in a structured format. So going piece by piece, we started small. We had a few KPI that we felt were really important. We do have grants and things of that nature that those are already handed to you. You need to collect this information. But we wanted to collect some things that were specific to the clinic to make sure that it was going to flow well. And again, primarily focusing on access, since that's one of the biggest issues in behavioral health care today, is that there's just not enough clinicians, there's not enough access across the country, let alone in our communities. So however you do it, I would just say that have the strong foundation, make sure you have your software in place and you have people to grow out those programs. Moving forward with that, make sure if you're using the time to collect the data that you're using it and making data-driven decisions. The other thing in behavioral health care that we've found really helpful is we have actually kind of leaned a little bit, I would say we approximate measurement care. So basically what I mean is we utilize an outcomes assessment. It's a universal screener called an OQ, outcomes questionnaire. And it's been really helpful for us to be able to have a statistically significant statistical tool using the RCI, which is the Reliable Change Index, which has plenty of research behind it. Won't go into the details, but using that tool, we deliver it before every session. And so every time someone's coming to get care, even if they only come to see us 4 times, every time they're coming in, we're measuring how they did from that week prior or that time span in between the first one or whatever number it was. We're able to make a quick change depending on what they're presenting, their symptoms are that day, because as we all know, a lot can happen in a day, a week, even an hour. Your life can change drastically. So we use that to be able to make quick decisions, to make every single session count. And that's actually really shown so far that we're 30% above the actual national benchmark that was shown through research on the OQ, which is supported by that evidence-based practice of doing measurement-based care in BC. But those are just some of the things that I would say could be helpful. I know it's focused primarily on behavioral health care, since that's what I work in, that's what I know best. But I think even if you're starting a quality insurance program, quality improvement program in healthcare, or you've got one that's already working, always go back to the validity of the data is really what's going to set the program apart and make it accurate when you're using those data points to make your data-driven decision. So having all that, either way you look at it, start with the software, have that team be able to grow, and I think that it'll really make your program successful with a little bit of strategic planning and looking out for more than just the patient's care directly. Looking at your clinicians can also make a big difference in the actual care that's driven to the provided to the patients. So I will leave it there. Thank you for your time, everyone.
Okay, is this on? Perfect. All right, well, thank you, panelists, for that presentation. So we do have about 10 minutes. Are there any questions that anyone from the audience would like to ask the panelists?